So good evening, all. So from the very enlightening talk, now we come to the what we do in clinic without much the experience or the evidence that we have with the non-immunocompromised or non-autoimmune conditions. So my talk today is on treating patients with immunocompromised and autoimmune conditions in the clinic. So this is a scenario where we need to. So this is the scenario where chemotherapy and the immune checkpoint inhibitor has to be used in the context of immunocompromised or autoimmune disease. And we know that we have pretty much a good experience as far as chemotherapy is concerned. But when we use immune checkpoint inhibitor in the context of an autoimmune disease, that's really a fine balance where we will look at the status of the autoimmune disease. If it is aggressive and if it is active, then we should look at the stage and nature of the cancer, because we need to have a fine balance between the immune stimulation as well as the immune repression, because either one of them can be life threatening. For example, if you have a bad exacerbation of an autoimmune phenomenon, we know that that can be life threatening. So it becomes real balance. And why? Because it is important. I'll come in subsequent slides, because we don't have enough data to fall back on. So if you look at chemotherapy and immune checkpoint inhibitor in the context of autoimmune disease, in the clinic, I think the commonest autoimmune disorder which we see day in and day out is diabetes mellitus. And we have sort of learned the tricks on how to manage it, and we don't consider that as an absolute contraindication for chemotherapy, at least. We know that when we have to use high dose steroids like in myeloma, it becomes challenging. And also in low dose steroids, prolonged use like either with abiraterone or docetaxel in castrate resistant prostate cancer, we have issues if there is uncontrolled diabetes. On a daycare clinic, if you use 5% dextrose as a vehicle for some of the chemotherapeutic agent, we know that uncontrolled sugars cause a challenge. Of course, in the COVID era, the prolonged steroid use elsewhere, now we oncologists have to face the after effects, and we need optimal glycemic control when they come back to us for chemotherapy. Especially when we have prolonged steroids in COVID, we know that that can have an impact on patients who have received immune checkpoint inhibitors, and it may lose its efficacy a bit. We also need to watch out for steroid related complications in the COVID era, post COVID, when they come back to us for chemotherapy, including pre-existing fungal infection, including mucormycosis. An interesting fact is, if you have immune checkpoint induced diabetic ketoacidosis, whether in the background of a pre-existing diabetes or autoimmune DKA, then that becomes an absolute contraindication for further. So if you have the immune checkpoint inhibitors induced diabetic ketoacidosis, then it becomes an absolute contraindication for its use in the further lines. So if you look at immune checkpoint inhibitors, the general guidelines, it is usually instructed to avoid patients who are known to have active autoimmune disease, in the pretext that it will avoid, it may to prevent avoiding the worsening of flare-up of the underlying autoimmune disease. But if you look into the data more carefully, so the autoimmune diseases which usually are a problem are SLE, which is active, rheumatoid arthritis when they are on disease-modifying drugs, Sjogren's syndrome, inflammatory bowel disease, and psoriasis. We had a patient who had psoriasis under good control, but we had an acute exacerbation when we introduced immune checkpoint inhibitor. So generally, they are considered to have a very high risk of flare-up when treated with immune checkpoint inhibitor. And the main worry is these patients were largely excluded from clinical trials in immune checkpoint inhibitors, because they felt that there will be possibly higher toxicity rates, and the autoimmune side effects may be difficult to distinguish between the pre-existing autoimmune or is it due to the drug-induced. And we also know that some of the cancers that we treat with immune checkpoint inhibitors already has a coexisting autoimmune phenomenon, like renal cancer, where it can be up to 1 in 3, and in non-small cell lung cancer, 1/4 of the patients. For example, we know myasthenia gravis as a well existing paraneoplastic syndrome in non-small cell lung cancer. And now with the use of immune checkpoint inhibitors, the MG associated with pembrolizumab is a well-recognized phenomenon. And when we have myasthenia gravis exacerbation grade 3 and more, the recommendation is generally not to re-challenge pembrolizumab again. And also, since being a class effect, we are not supposed to use other PD-L1 blockade also if you have myasthenia gravis. So these are new challenges that we are facing. So what is the evidence of immune checkpoint inhibitor in the background of autoimmune disease? The first large series came up in 2019, which was a retrospective study presented in ASCO, which looked at 2,425 patients treated with PD-1 inhibitor with advanced NSCLC, and 22% of them had autoimmune disorders. In that study, the immune checkpoint inhibitors were used regardless of patients' history of autoimmune disorders. They found that 94% of the patients received PD-1 inhibitors, and 22.1% of those patients had evidence of active autoimmune disease. And when they looked at the data, though retrospective, they felt that there was no hampering of survival. The median overall survival for the entire cohort was 12.4 and 12.8 months in the patients with autoimmune disease and 11.5 in those with active autoimmune disease. Overall adverse events frequency was similar in both the groups, and the researchers did report an increase in adverse event in the AD patients, including endocrine, gastrointestinal, blood disorders by nearly 1% in each category. So the study discussion was that patients with the background of autoimmune disease can be considered for immune checkpoint inhibitor based on careful clinical assessment after weighing up the benefit and risk. And it should not be a frank contraindication for or absolute contraindication. There should be a discussion with the treating physician like a rheumatologist and the patient about the benefit and risk of the treatment. And the careful monitoring is very important of early symptoms and signs of toxicity is crucial. 9 or 10% had active autoimmune disorders categorized as mainly rheumatologic, endocrine, and IBD. Of these, 55% of patients were treated with the immune checkpoint inhibitor, and they were treated either with anti-CTLA4 or anti-PD-1 or a combination of both. So again, the incidence of immune-related adverse event of grade 3 or higher in patients with autoimmune disorders were 30% with anti-CTLA4, 17% with anti-PD-1, and 44% in the combination arm. And this was almost comparable, like 30%, 13%, and 48% in the non-AID arm. So the patients with autoimmune disorder more often discontinued anti-PD-1 treatment because of toxicity and than patients with autoimmune disorder. We also found out interestingly that there was more choice of a BRAF targeted therapy being used in patients who had an active autoimmune disease. Patients with IBD, which is a practical point, were more prone to anti-PD-1 induced colitis. So this is one subset we need to watch out for because this was statistically significant than patients with other autoimmune disorders. So anybody with an active IBD may be at risk for increased risk for autoimmune colitis when we give them immune checkpoint inhibitors. The response rate was similar in patients with or without AID, and the survival also did not differ between patients with and without autoimmune disease. So the median survival was 13 months and versus 14 months, which was not statistically significant. So they again concluded that response to immune checkpoint inhibitor with either anti-CTLA4 or anti-PD-1 or their combination for advanced melanoma and overall incidence of any grade 3 or higher was similar in patients with than without pre-existing autoimmune disease. Severe colitis and toxicity requiring early discontinuation of treatment occurred more frequently among patients with pre-existing IBD warranting close follow-up. So we are more familiar with another immunocompromised situation like HIV, although we know that HIV-related cancers appear at an earlier age with an atypical and aggressive pathology and aggressive clinical behavior and advanced stage, thereby leading to poorer outcome, rapid progression and higher rate of relapse and worse response to treatment. So the general principles, as far as at least chemotherapy is concerned, is to treat them similar to non-HIV infected patients. Only thing to watch out for would be the antiretroviral therapy, especially when they are multi-drug anti-ART, then may result in additive cytotoxicity or other drug-drug interaction, which we need to watch out for. Otherwise, there's no major difference. Again, the data for immunotherapy, as far as HIV is concerned, we have recent data consistently suggesting that checkpoint inhibitor immunotherapy can be used safely and effective in HIV patients who are under control as far as HIV along with cancer. So there were important clinical trials evaluating the inhibitors, PD-1 inhibitor, either nivolumab or pembrolizumab, or PD-L1 such as nivolumab, exclusively in HIV positive patients, and they have reported similar efficacy and immune-mediated toxicity compared to that patients who are non-HIV. So immunotherapy did not negatively impact either the control of the HIV, including the HIV viral load, or the CD4 count status. So this was a safety of pembrolizumab, which was a phase 1 open-label non-randomized study, which looked at HIV patients who had advanced cancer as well as CD4 count, which were equal to or more than 100, with at least ART for more than 4 weeks and HIV viral load of less than 200. Again, this trial excluded patients who had coexisting autoimmune disease requiring active immunosuppressive therapy. So here, among the 30 participants, they had a wide range of Kaposi sarcoma, non-Hodgkin's, and lung cancer. And the safety was observed over 183 cycles of treatment with pembrolizumab. And most treatment emergent adverse events, at least possibly attributed to pembrolizumab, were grade 1, which was, and 20% were grade 3. So the main, again, the side effects included hypothyroidism, pneumonitis, and hepatitis, and a musculoskeletal event. One interesting aspect was one participant with pre-treatment KS herpes virus viremia developed a polyclonal Kaposi sarcoma associated B-cell lymphoproliferation. That's the second cancer, and died. In all participants, increase in CD counts were not significant, and best tumor responses, including the partial response, CR, and stable disease and progressive disease, were all comparable to the non-HIV status patient, and there was no major difference. So the relevance of this study is that pembrolizumab has acceptable safety in patients with cancer and HIV who are on ART and a CD4 count of more than 100 can be safely administered pembrolizumab, but the KSHB associated B-cell proliferation is a reality, and we need to be aware of that. Anti-PD-1 therapy can be appropriate as per the FDA and other approval indications in this population. So the meaningful conclusion we can draw with limited literature review is that in the real world scenario, we have patients in our clinic with autoimmune disorders and immunocompromised and who are necessitating systemic therapy. We know that it is not an absolute contraindication for either chemotherapy or immune checkpoint inhibitors, but we have limited data for that. And we need to keep them under close follow-up, watch out for early exacerbation of autoimmune side effect, have a team management with the rheumatologist and other physicians involved, and we should have a personalized approach for these difficult to treat patients. Thank you very much for the opportunity.
Thank you, sir. Thank you for an excellent presentation, talk. So the bottom line is that we need to have a balance between efficacy and toxicity, and we have to have a thorough discussion with the patient and the family. So there's no absolute contraindication, but we have to have a balance. So if we have any questions, my coach here has any question. Any questions? Dr. Biswajit is there?
Okay. Rajiv, I don't know, this is maybe unrelated to this, but we had one patient who had a renal cell carcinoma who was on immunotherapy and was down almost like 6 months, 8 months down this thing, and we had to do a response assessment. So we just before the response assessment, the patient had taken a vaccine shot for the COVID. And when we did the response assessment, there were no new site lesions, but some of the old site lesions, there was some size increase and some increase in the spots. So that time we decided that we will keep 4 weeks and then we will review the scans. And exactly after 4 weeks, when we repeated the scan, all the lesions had disappeared and she went into a kind of CR. So have you ever, is there any data?
The most of the data as far as imaging and COVID vaccination comes from breast cancer. So they say if you have a COVID vaccine and if you are planning mammogram or PET scan, you should at least give 6 to 8 weeks time, because you can have lymphadenopathy and other metabolic uptake which can lead to confusion. So Basically, if you are on vaccination or you have had active COVID, it's better to postpone 6 to 8 weeks after for the imaging, especially the PET scan. But I don't have experience as far as the immune checkpoint inhibitor is concerned. But we have been careful in looking at the date of vaccination and try to postpone imaging wherever it is feasible.
Yeah, I think quite important. I think to schedule that scans and this thing.
So your experience with the like we have patients with immune checkpoint inhibitors, and due to toxicity, they have to have on steroids. A patient has some autoimmune condition and patient is on steroids, and the efficacy of immune checkpoint inhibitors vis-a-vis what not on steroids. Your clinical experience, do you have some experience with this?
Very limited clinical experience. I've had few patients on rheumatoid arthritis on multiple drugs. And also, as I told, I have recently a myasthenia gravis patient who is on steroids. But luckily for both of them, there was good efficacy even though they were on steroids. So when you look at the literature, they say if the autoimmune disease is leading to steroid dose, which is less than 10 mg of prednisolone per day, that should not hamper the efficacy of immune checkpoint inhibitors. If they are on low dose steroids and autoimmune disease is under control, that should be fine. But as you rightly told, if they are on high dose and prolonged dose of steroids, you will definitely have blunting of the immune checkpoint effect.
I can't see any question. Anybody else has any other questions? I can't see anything in the chat box.
Yeah, I think indeed it was a great session, and questions may keep coming, but we have to keep the time bar also in the mind. So I think we have to move. Thank you, everyone.
Thank you.
And
Thank
indeed,
you.
it
Thank
was
you,
a great talk and very unusual scenarios which we face in the clinic and get challenged daily.